I'm Sarah Smith, family doctor, clinical day advisor, and the chatting coach. Welcome back to Sustainable Clinical Medicine podcast, where we're going to be interviewing peers or world experts who can help us think about our clinical day in a way that is more sustainable and create time for our lives outside of medicine. Hi, everybody, and welcome back. Today we have with us Dr. Heidi Baker. Welcome.
Hi, Sarah. It's lovely to be here. Thanks for inviting me.
Yeah. Tell us a bit about you.
So I'm a doctor working and living in Aotearoa in New Zealand at the moment, but born and bred in Australia. I've been here for 21 years. I came across here originally as a pediatrician and then veered and segued into emergency medicine, working both in adults and children's and some pre-hospital work, and did that for probably 15, 17 years. And then more recently have stepped out of permanent public ED work. I now locum in a different hospital and I'm running a private pediatric practice in Auckland and then do some clinics down on the South Island in Queenstown.
There you go. And is that new clinic work back into the pediatric space?
It is, it is. I do a little bit of adult work as well. I do some adult AHD assessments, but largely otherwise in the pediatric and I guess quite adolescent space.
Yeah. That is a diverse career. So tell us a bit about why we have such diversity there, because pediatrics is already hard enough. And then to go back into emergency medicine and adding adults in, like they're not just easy transitions. Tell us a bit about what happened there.
Yeah, I think I've probably always loved most things that I did. I ironically did almost a year of genetics, and I've really enjoyed a lot of the work that I did. I considered doing ED originally, pediatric ED, but had some life events at the time that meant having a decent sleep schedule I needed to prioritize. And so I guess that's how I went into general pediatrics and neurodevelopmental pediatrics. And actually came across here, I still felt like I had the travel bug in me. And so I came across to New Zealand actually originally to do some multi-sport events, to be completely honest, to be able to kayak and paddle, which I couldn't do a lot of in Melbourne at the time, which is where I'd done my original training. But yeah, I came across here and actually at the time, there wasn't a lot of conversation around neurodevelopmental conditions in children, which is a lot of what my training had been in. And so it was part through that sort of disconnect of my training and what was available in a workspace that led me to do some ED locums and then I guess reignited the love of ED that I'd had during my training. And the system and hospital that I was working in at the time here in Auckland actually has two separate hospitals but co-located. And so I was one of the first people to be able to be working across the two departments, which was a bonus and came with some challenges in terms of rostering and things. And I guess through that, doing some of the pre-hospital work as well, I was able to bring that pediatric experience because otherwise a lot of our ED doctors from that hospital only worked with adults. And so I was able to bring that ED lens. But I guess as time went on, the challenges of shift work and the toll it can potentially take on your body started to catch up with me. And through a few I guess I'd started to proactively make the decision to be back and do a bit more of the pediatrics and the work that I loved. But then through a couple of health events, that was probably fast forwarded somewhat. And I think as well, post-COVID, as a lot of health, I feel, has become a bit more transactional in the hospital. I really like the relational side of healthcare. And so I guess moving back into the private world and the luxury of time in a way that can give you has enabled me to fall back in love with medicine again, when I will be honest and say I was starting to potentially question as to how sustainable it was going to be as a career.
Yeah. Okay. So it was more that fast-paced and shift work and long hours and multiple places that was starting to add that real, I'm not enjoying this, isn't sustainable. Would that be
Yeah, I think the shifting nature of shift work, an unpredictable roster, the lack of autonomy and being able to at least predict the shifts and hours that you work on top of being a mother of three kids and three teenagers who themselves have their own needs and demands and need to be driven to various different places. I think it just makes it increasingly challenging. And I felt like I wasn't really showing up at work as the being able to practice in the way I wanted to practice, but I equally wasn't being able to show up at home in the way that I wanted to be as a parent as well. And so as much as I would love to think that we can do it all, as many people say, you can't do it all at once. Really just had to make some decisions around that as well.
What does a full-time roster schedule as emergency department doctor in New Zealand look like? Like how many shifts a month are you or week are you looking at? What does it look like to do a shift roster there?
Yeah, there's possibly some variations across departments. I guess I can only really talk from the department that I worked in full time. So it would typically be 3 full-time shifts a week and a full non-clinical shift. And I worked night shifts for 12 years, 10 to 12 years as my weekend component. So we all do 1 and 4 weekends, but I had done them as night shifts, partly, I guess, actually for 2 reasons. One, at the time when I started, it worked with family and my husband works full time, but also actually we have a philosophy of equitable healthcare. And I would argue that, and in fact, the ASIM research has shown that the after hours presentations for different ethnicities and the critical of those presentations is that would actually demand, one could argue, senior support after hours. And so I had actually done it, yeah, for dual reasons, really. And I guess did that for, yeah, 10 to 12 years. Not everyone does night shifts on our senior roster. It was an opt-in situation at that stage. Most of the new consultants would often start doing some night shifts now, but back when I started, I was one of only 2 people doing them at the time.
Yeah. And we know that night shift has an impact on human physiology. So 12
Yeah.
years of night shifts is a lot of physiology
Yeah,
implications.
yeah. I did days and evenings as well, but that was my weekend component. Yeah.
We know that sometimes you can just be a nocturnalist in the emergency departments, like in, for instance, the US, they
Yes.
have nocturnalists, which
Yes. Yeah.
hats off to them, but that's a big ask of their body.
Yeah. Yeah. It is. There's interesting and fun elements to night shifts as well in the terms of ability to maintain your clinical skills, which I think as senior staff sometimes we stepping into that teaching role, if you're working in a teaching hospital, means that you actually become a lot less hands-on, whereas on a night shift you remain hands-on. So there's definitely benefits to it from a maintaining skills aspect. But yes, the physiological toll, I think, is something that we don't necessarily talk about or consider, particularly for a pretty young specialty.
Yeah. Even looking at essentially 12 shifts a month, essentially, that's 50% more than some other full-time emergency department positions in other countries. So, like, we're
Mm.
looking at a big load, a big shift requirement on you as well. So, yeah. Okay. So, we had another transition. How easy was that to do?
Back into pediatrics
Yeah.
or it was challenging, I think, particularly because it was not so much challenging clinically, but challenging from a personal level because essentially I was setting up a business
Mhm.
and having worked within the private system, I'd had the luxury of receiving a paycheck every fortnight and almost never having, probably never having to write an invoice and think about how you set up all the business systems, how you gain access, how you choose your patient management system, the needs and requirements around privacy and access to special authority scripts is what we call them over here for
Yeah.
restricted medications. So it was a really steep
Mm.
learning curve from that aspect. And whilst there's a challenge in that, there was a degree of having to learn. I actually just need to give this up if I want to focus on the clinical side of things because the time it was taking was pretty overwhelming. Yeah.
So, was private the only option? Were there other clinics who said, "Hey, come have a room at our place, we'll look after you," or there wasn't that available?
There could have been and would have been if I'd chosen to. So I initially was doing clinics down in Queenstown. We go down there quite regularly, and they had a reduction in the pediatric services that were available to them. And for anyone who has travelled to Queenstown in the last 10 years will be well aware of the population expansion that's happened there. And so I was originally doing clinics down there just as a visiting person amongst my emergency department work and actually only going down once a month initially. But as time's gone by, that has increased a bit. And then I've set up practice here in Auckland. And yes, there could have been other clinics that I joined. There certainly were clinics, although private work in New Zealand, especially for pediatrics, is relatively in its infancy. I think, to be honest, probably that autonomous nature of having been an emergency doctor meant that I really wanted to create my own thing and
Hmm.
have a bit more flexibility. And in around a roster at the time that was not predictable, I needed to be able to choose what days I could work and
Mm-hmm.
not be at the mercy of a sort of bigger practice.
Yeah, no, fair enough. It's just interesting to see what made you take that step. So this is you setting up a business. You get to decide how many patients, what days you'll work, how long your visits will be. But then if it's 12 years later, if you'd been in the emergency department that whole time, EMRs have changed and potentially item numbers have changed that you can bill and how much you're going to invoice people. All of those decisions, that's a lot of decisions.
Yeah, it's been a lot of yes, deep learning and trying to I think actually learning to value your own skill and your own time is a really big mind shift and not something that I think we're particularly good at. And it's also not something that's spoken about. There's a lot of don't talk about contracts, don't talk about what you bill, don't share and discuss. And so that even makes it a bit more challenging again because you're trying to predict ahead what the cost of running a practice might be and therefore trying to ensure that at least it's sustainable and you're making sufficient money to be able to live. So yeah, it's been an interesting journey. We don't have, I guess we don't have Medicare like Australia is. So in terms of the billings and things, it's different. But if you're affiliated with insurance companies, then there's negotiations around those contracts that has to come into it as well.
Interesting. Okay, I really don't know the New Zealand system very
Mm,
well at all.
yeah. Yeah.
It's one country I haven't been to check it out and to
You'll have
work
to come
there. And to,
across.
I
Yeah.
will. I will have to
Yeah.
come visit. Okay, so are you still doing that, or is that now something that you're not doing? Where are you at with that now?
So now I have rooms in Auckland, which I primarily work out of, and I go down to Queenstown about once every 3 weeks to do a couple of days of clinics and then telehealth in between. And I'm, as of end of 2025, I've stepped back from my part-time ED career and now locuming in ED in a different hospital, just a bit closer to home, but still within the Auckland catchment.
Interesting.
Mm.
Tell us about pre-hospital work. What is that? You were talking about pre-hospital.
Yeah, so when I was doing it, and I don't do that anymore, I was working with, at the time it was called Westpac, a helicopter service. So it was relatively, I think it had probably been going about a couple of years when I joined. And so it was sorry, wasn't, it had been going much longer than that, but having medical staff and doctors involved was in its relative infancy. And so we would have a crew of one, usually ED anesthetic or ICU doctor, a paramedic, crewman, and pilot. And so we would be tasked from Auckland and cover south of Whangarei, which is north of Auckland, and then down probably an hour or two south of Auckland, and then across to the Coromandel, which is across to the east, and then some of the islands off Auckland we would go out to as well. So we would do there would usually be 2 shifts in a day. Initially, it was just days, but then it did transition to also night shifts as well. And we would be based at the helicopter base doing some training, doing reading, learning. You might be doing some non-clinical work, and then you would get tasked with the crew to whatever the need was based on the call and the sort of dispatching from St. John's, which is our central ambulance service.
Interesting. That's very interesting work.
Beautiful way to see the country, and a real privilege to, I think, see the origins of ED work. I think we can make a lot of
Mhm,
assumptions when we work in the emergency department, one around what's happened at the scene and two
mhm,
around the care. And I'm
mhm.
certain that any ED doctor listening to this or nursing person will have heard some potentially judgmental comments made around pre-hospital care, but I think it really opened my eyes to we would often say the MacGyver skills that have to go on in
Mhm.
terms of managing patients in those settings, and actually sometimes the criticality of making a decision that, in retrospect, yes, you may have been able to do it a different way, but with the resources that you had in the scene, in the paddock, near the car, wherever it was that you were, you just actually had to make the best decision that you could make with the resources at the time. So I think it really gave me a huge respect for the pre-hospital work and the fireys and police who often are the first responders to these events. Also, a real appreciation for the isolation that people live in. I'd grown up between Melbourne and Adelaide, so I was very familiar with rural life and access to healthcare. But I think unique to New Zealand and probably where you're working as well in northern Queensland, I think the topography plays a really big challenge as well. And then you throw the weather bombs on top of that. And yes, it might look on a map like it's an hour by road to somewhere. But for example, with the Coromandel, if we didn't task by air to a patient, there was often at that stage only one ambulance that covered that whole region. And so if they had to be used to take a patient to hospital, then there was no first response for the area of the Coromandel Peninsula. So yeah, I think it just makes you appreciate the potential vulnerability, but the amazing service that both the road crews and the air crews can provide.
Yeah, yeah. That's another skill set on top of emergency department. So I did some critical care training as part of my attempt to, I will eventually go rural as an infant doctor. I did critical care training for 18 months,
Yeah.
and it's that I nearly got the helicopter retrieval part of it. You did, you just dove in there. But it's another skill set. Is that something that you had to pause and retrain to be able to go and join their retrieval service?
There's certainly a training program or course, a sort of a set of modules that we would do as
Yeah.
part of that. I guess I was fortunate in that I came with quite a lot of pediatric experience. And so
Mhm.
that's probably one of the areas that people are often quite nervous about in that field. And with
Absolutely.
that came, I won't say obstetric experience, but at least familiarity of attending
Hmm.
obstetric deliveries. So I think that gave me, or perhaps one could say that reduced that level of anxiety around getting called out to pediatric cases. But definitely in terms of the safety and the way that a team works and the factors that come into it, that was a big steep learning curve. Amazing crew that we did training with, real flattening of the hierarchy, lots and lots of simulation. And I think it was exceptional, the levels of simulation, and they would be done in a hangar. There would be a mock helicopter. We do them
Hmm.
out in the field. We do them out on some of the islands so that you really got a sense of what it was like. And then on top of that, I was lucky enough to go and do the London Air Ambulance training program as well, which is another step up again. And if anyone is ever given the opportunity to do that, I'd highly recommend it.
London, UK.
Yeah, yeah,
Wow. Okay, that's cool.
yeah. It was amazing. It was amazing. Sworn to secrecy about the simulations, but it was absolutely incredible.
Yeah, no, fair enough. Clinical courage is what's required to do what you're talking about. That ability to say, I can't do it the way I'd normally do it in the emergency department where it's a nice sterile environment and I've got everything at my fingertips. I need to figure it out in real time.
Yeah.
Not everybody wants clinical courage of opportunities like that.
Yeah. I think, to be honest, having grown up on a farm, I think you learn that adaptability. You don't
Mhm.
have a vet on tap, an electrician on tap, a plumber on tap. And so I spent hours and hours with my dad trying to help fix, make the best of what we can. And I think in retrospect, that probably gave me considerable confidence, maybe. I was going to say skills, but confidence in trusting in your own ability and that of the team around you. And I think if you can get to know the team around you, as we know in the ED, that just makes such a massive difference because what I may not have in my skill set, you hope and over time learn that someone else might have. And it's just having that comfort to say, this is not quite my place. My first resus or job that I did on that was a really confronting job setting that was somewhere that I probably will never go again. And it was wonderful to have a paramedic who was comfortable, had done that sort of thing before. It was really humbling, actually, because it was a clinical situation that in the hospital I would have just been on my game and run with,
Mhm.
just by nature of the setting. It was really disconcerting. And yeah, I think it was humbling. But from that, you learn the skills and the confidence to just say, I'll go back to my base
Mhm.
practices. And actually, you can apply those in most settings. You've just got to let go of some of the things that you think you need to hold on to
Yeah.
around it.
Yeah. All right. So you've done a lot of diversity in your career and popped a lot of skills in there. And what are you doing now? You're also helping work with doctors now. So what does that look like? What have you moved into there?
Yeah, so I did some coaching as well. I was one of the COVID sabbatical victims. And so I had a wonderful 3-month trip planned for 2020 for my first sabbatical after 17 years, which of course didn't happen. And so, as part of the decision, then I segued into doing some coaching. And initially it was actually around health coaching, which was great in terms of learning coaching skills. It was a really extensive 16-week program, but became acutely aware in terms of practicing medicine and health coaching. It's a very fine line. One could say it was an invaluable skill to learn, but through learning those skills, I then have moved into doing some physician or healthcare coaching with that. So working initially making myself available to trainees. I've done some work with some IMGs from Australia in terms of helping them adapt to the condition, the scene over there and getting through their exams and processes, and also with some exam people over here. And then being part of setting up a wellbeing program initially in Starship ED, which is the children's hospital I worked in, and then in the adult department as well. And then in the last 12 months or so, been doing a little bit of coaching through Capstan, who are doing a research project on offering coaching for doctors. So doing some of that and then some of my own coaching on the side.
What made you interested in doing health coaching? And at that time, what were you looking to use that for initially?
I think it's an invaluable skill to have clinically. I think we're very practiced, and particularly in emergency medicine, with our sort of algorithmic approach to things, which can help you get to the diagnosis more quickly, but I don't necessarily always think it helps us get to the root cause of the disease process or the non-compliance or the reason that someone's presenting when they present. And so I found it invaluable in, I guess, not quite flipping around how I approach patients and things, but it certainly has helped me more often get to the source of an issue or the source of behavior change that needs to happen.
Yeah.
And now in my pediatric work, and it's absolutely invaluable in terms of how I interact and work with particularly teenagers, but also I think with parents as well. It's a much more, I guess, sort of proactive and forward-thinking approach, and really entrust in people that they've got the answers within them rather than that hierarchical, I am the doctor and I can tell you or inform you what to do. It's much more about trying to pull it out of people. And so although, yes, it might be in a clinical setting, the skills that I've learned through that have really enhanced the way that I practice in my medical work as well.
Yeah. When you signed up for that 16-week program, was it for that to help your patients in the settings that you were working at the time? That's what you had used it for opportunistically, that it was going to be helpful for you in your clinical space?
I think it was probably dual. It was partly clinical space, and it was also with a view to potentially doing some physician coaching. One of the things I really liked about the program that I did then was actually the duration of it. So a lot of coaching courses are like a day or
Yeah.
a weekend, and that still provides valuable skills, but this was actually over 4 months. It was 2 to 3 hours of coaching a week over that time. And so it was a real opportunity with the same cohort of people. So it was a real opportunity to move and watch each other start here and end up in a different place alongside, I guess there was a trickle of health stuff that ran through it. I guess coming from having done medical training, the depth of the health knowledge was not the same as what I obviously had to learn throughout my training, but nonetheless, the skills that came with it, and in actual fact, working with people who were often not medically or health trained was actually quite valuable, because I think I got into those coaching sessions and got a real insight into the thinking and the behaviors and the blocks for non-health people. So it probably actually enhanced my clinical skill more, even though I'd probably gone into it as much around thinking that I might be ending up coaching some doctors in the future.
Yeah. All right. I totally get it now why you had looked at coaching as a new skill set for yourself, especially if you've got those teenagers coming through and, like you said, talking to parents, and then you've got learners under you constantly in the emergency department. Absolutely. Yeah,
Yeah.
got it. How do people find you if they're looking to hear about more about what you're doing with doctors that you're coaching and mentoring?
I can be contacted through a website. Pod Health is my practice that I work with. And that's one of the best ways probably to reach out to me. Otherwise, people can reach out to me via email as well, which I'm happy if you want to share in the notes.
Yeah, absolutely. We can totally do
Yeah.
that. All
Yeah.
right. What have we not talked about that we should be talking about?
I think it's probably the value of coaching. I know that there's been a lot discussed around it, but I think in the current environment, it's easy to feel a little bit like the house is on fire. And I think there's a lot of people looking to move out of health. And I think for me, part of training to be a coach, but also through that process, receiving coaching myself, yes, has enabled me to pivot within medicine somewhat, but
Mhm.
actually has brought me back to being in love with medicine and health again when I was ready almost to walk away. And I don't think I think without coaching, there is a real chance that I would have walked away. And I guess we've already touched on, I'm happy to pivot and to relearn new
Mhm.
skills and things. And so I was actually comfortable to do that. But I'm so glad that I didn't. I love my work now. I love the practice I do. I love the mix of going in and doing some ED locums, having a bit more autonomy and choice over when I do the shifts, and
Mhm.
hopefully bringing still my skills into that setting. But equally, I love the work that I'm doing here. So I think there's quite a perception, I suspect, sometimes from organizations that if we offer coaching to our medical staff as part of their program, that they're going to get coached out of working in health. I actually think the flip is equally, if not more possible, in that it
Mhm.
might just enable people to become a bit more conscious around what it is within health, what it was that drew them in the first place, how they could just iterate and adjust things so that they stay in health, but doing the things they love, which by definition is going to make you more enthusiastic, engaged, contributing, part of a team, and really
Mhm.
shift that momentum. So I think we're looking at it. I get a sense that some people look at it a bit dichotomously, that if we offer this, they'll be out. But actually, I don't see it that way. Yes, there'll be some people who may exit, but they maybe were going to do it anyway, and they may not be contributing in a 100% fulfilling way anyway. And actually, we should all have the opportunity to change our life course if that's what we want to do. So I think if any organizations are wondering about offering coaching as part of what they offer for trainees or offer for their doctors, I would really encourage them to do it. And I'm actually at the moment doing some organizational coaching through an Australian company, and it's fascinating. That's not within health necessarily. There are people from all sorts of disciplines, but I think it makes you realize that so many other industries, it is just an embedded part of their culture that they
Mhm.
offer coaching to their staff. I just find it's fascinating that within health, we've been pretty slow to the party in seeing it as an integral part. Yes, we have peer review, we have mentoring, we have supervision, but that's often once again an ambulance at the bottom of the cliff approach rather than having it
And it's
just
so
embedded as our day.
the people who are given those positions as mentors and supervisors, we're not pulled aside and given 16 weeks of coaching experience to do that.
No.
Where other burnt out, disillusioned doctors try
Yeah.
to help your colleague along.
Yeah.
And so we're wondering why this doesn't necessarily work. Medicine is, yes, you're right, behind the eight ball when it comes to the actual skill set required to help someone thrive
Yeah.
and create sustainability within their workplace.
Yeah.
And the coaching piece allows that to flourish more successfully within
Yeah.
the very broken systems that we work.
Yeah. 100%. And there's this sense of a peak when you get your specialty training or you get
Yeah.
your qualifications. That's it. And that's almost the peak of this. Shouldn't say the peak of the skill set, but there's a sense that responsibility is over. And
Yeah, they should be fine now. They got there.
yeah, I think that's just the beginning of all the other things that come into our work lives that add complexity and mean that we're at risk of burning out, of health implications that might well be because of the lifestyle that we've been set up to do. And the speed expectations is escalating so quickly, and we are reaching,
Mm.
I think, a little bit of a teetering point of not only what's sustainable within the people working in health, but what's actually sustainable within the bigger system to offer people, even though we can do we actually have the resources? That's at a systems level, but it also
Mm.
sits within us as people, I think.
Yeah.
So yeah, for coaching, I think it just enables you to sit and ponder of what's my role in that, both within my own house, but within the bigger house of the system that I'm working in.
Yeah. I
Mm.
like that. I have not considered the idea that organizations would be concerned that if you give this sort of opportunity to doctors, it will help them want to leave. We know that a significant proportion of doctors are looking for an exit strategy
Mm.
already. That's
Mm.
just a known. They've done studies. The Canada
Yeah.
stats came out, and there's a good fat number of people looking to exit. And this is an opportunity, like you said, the evidence is coming out as to physician well-being with very few interventions with regards to the coaching space that can completely improve things like quality of life, burnout rates, feeling satisfied in their job, feeling more joy towards job and less dread in the workplace.
Mm.
We have those studies coming out. There's good evidence now that these coaches in the well-being space are not asking doctors to leave. Some are there to help step you out of your job or transition or leave medicine, but the significant number of them coming into organizations are there to help
Mm.
on help the people on the ground.
Yeah, and to get some clarity, and I think for professions that see and potentially have to carry such stories or visual images as we do in emergency medicine, which I'm sure you've seen as well. I think it's fascinating that it's not, I'm cautious to say mandated, but
Yeah.
even doing significant peer review is really only mandated again for me now that I'm doing pediatrics, and by definition, a lot of that is mental health. Whereas, I guess, for example, in ED, we do peer review, but the requirements for that, it can see much more group-based stuff and things, whereas I just think it really should be something that, a bit like doing your procedures, is a skill set that you just learn a lot more one-to-one reflective practice. Because after all, that is often what we're asking our patients to do, is to reflect on what habits, behaviors, things that they've learnt about themselves may have contributed to their presentation or their disease process.
Mhm.
Maybe we need to put the mirror on our own profession and say we need to start doing a bit more of that ourselves as well.
Yeah. I was talking to a psychologist on the podcast a while back. She said part of their training is that they're required to have a psychologist and then they're required to have one throughout their career. I'm like, God,
Yeah,
they've got it
yeah,
right.
yeah, yeah. No,
It's not
absolutely.
oh no, there's something wrong with her. It's, no, this is important and it's required.
Yeah, yeah. And the department that I was working in, we've actually had a psychologist as part of our department for about 5 years. I'm probably getting that figure wrong, but that's been hugely valuable for staff. And that's an anonymized person who is available 1 to 2 days a week, and outside of that, if you want to, but a consistent person as well. So I guess the advantage of that versus we have EAP, I'm not sure what it's called in Australia, where you can get access to some sessions, but often through doing that, you're not quite sure who you're going to see. Whereas having someone who is, in a way, part of our team, they really get a sense for what's going on in the department and what shifts are happening and things like that. And that the uptake for that has been phenomenal. And I think certainly for EDs anyway, if there's anyone who's considering that as an opportunity or an option, or whether that's needed, I'm certain that the people in the department that I worked in Auckland would be happy to talk to them about that. But it's been really valuable, not just for medical people, that's made available to anyone in the department. And I think that's the other thing that's super important
Yeah.
in any situation, but particularly I think in ED, our nursing staff, admin staff, orderlies, cleaners see as much of the trauma as we do, and actually often don't have the context to it. And so the psychologist that we have is available to every member of the team and is
Mm.
utilized by every member of the team. And I think that's a really powerful message that we all contribute to the
They don't do any patient care then. They're just there as a psychologist
yeah,
for the purposes of the staff to see them.
yeah, yeah,
Wow.
yeah.
That's an
Yeah.
interesting model. I'm interested in that. Do they have an office that you can just knock and go in, or is it put your name on the board, or how does that work?
Yeah, there is a space that they will be at. And so I guess you can contact that person ahead of time and say, my shift starts at 12 and have you got something available at 11? But otherwise there is an opportunity just to go, and if there is space on that day, to go and have a conversation. And that can be hugely valuable if you've been involved in a big resus or had a complaint or a difficult patient interaction and you don't have a regular peer review process. I think that can be a great opportunity. And we as SMOs are afforded within the public system continuing professional development money. And so we can access peer review. And I've certainly had a process set up for many years of having peer review that I've now continued outside of that role. But for a lot of our staff, they don't have access to that, and nursing staff and
What
our
is peer review look like for you? So when you say peer review, I'm not sure that we have that here or in Canada. So what is a peer review?
So I guess it can be a one-to-one, like professional
Hmm.
supervision peer review. And so I have that about
Hmm.
once a month. On top of that, for the role that I'm doing, I am involved in a group with some largely adult psychiatrists that I similarly is once a month we sit and do peer review. And then I also do some creative peer supervision that's facilitated by a woman in Australia from Tasmania who's a music therapist. And then the other practitioners are psychologists, art therapists, psychotherapists. And so similarly, that's an opportunity that's once a month to, I guess, through the music and the creative side of it, get a bit more embodied in your reflective practice, but also it can be bringing particular cases, particular difficult interactions. So I guess not so much the clinical aspect of cases, but how they've had an impact on us. And I guess I'm fortunate through that with the group I'm with now is into our third year. And so you really start to develop relationships with those people and I guess start to bring a bit more of yourself into that space and the impact that your clinical life is having on you, but in many ways, the impact that our personal lives can potentially have on our clinical practice as well. And I
Okay.
think
Yeah.
we have separated the human from medicine for a bit too long, from the human from the doctor for a bit too
Yeah.
long. And
Yeah.
the sooner we can come back to that, I think the sooner we're going to understand the competing demands on our patients and our teams a lot better as well.
Yeah. Do the peers who provide the peer support put their hand up and say, I want to be a peer-to-peer person? Or is this an expectation that everybody's a peer-to-peer person and you just find your people? How do you tend to make that happen?
The I think it depends on the setting. And so
Hmm.
the creative one I do that is facilitated by someone who is provides professional supervision. The group with the psychiatrist, they've been going for some time. I've joined them more recently. There's probably tends to be one or two people within that group that, generally speaking, facilitate it, but I'm not super familiar with the history of it. I've also set up a group with my emergency department women. So we meet,
Hmm.
we've called it seasons, I've called it seasons of practice. We meet on the first of each change of season. And in a way, I guess for me, and I've done professional supervision training as well through Auckland University. So in a way, I will lead that, but everyone else will bring cases and things. But that's been an opportunity as well to invite people, the new trainees. We've got some people who are coming back from having babies and returning to work and things, and then people like me who are at the sort of other end of their career or in the middle towards the end of their career. And so that's been a nice opportunity to share in some of our learnings along the way and reflections, but equally have them bring their new eyes and new lens to the clinical space as well. So
Yeah.
yeah, it tends to be, I guess I facilitate that, but everyone else will bring things as well. I think there is often, as we touched on before, in terms of that mentoring relationship, there is a risk is probably too strong a word. There is often a situation and someone is asked to be a supervisor or asked to do the peer thing. But I think, again, unless you really understand the lens that you should be providing that with, there's a
Yeah.
risk that it becomes that top-down
Yeah. Yeah.
informative practice rather
Yeah.
than explorative kind of practice.
Yeah. I get that. I understand that. I did some trauma-informed coaching after I'd done coaching, and I realized just that next level of understanding I needed in order to facilitate safety and
Yeah,
conversations with our colleagues. So yeah.
yeah.
Thank you so much for this conversation, Heidi. I think this has been really interesting to see all the different ways that coaching and mentoring can be distributed, just different ideas, which is fantastic. Thank you for that.
No, thank you, Sarah. Thanks for the opportunity to speak and to catch up.
Yeah, totally. You guys have a great rest of your week, and we'll see you next time.
Bye now.
Hey, if you found this podcast episode helpful, I would encourage you to like and subscribe. Every time you do, you help a colleague or friend find our podcast, and it can help them too. Don't forget to share it along with your friends. If you're looking for extra help, don't forget we have Charting Champions for physicians and Smarter Charting for nurse practitioners and other clinicians to help you get home with your work done. We are helping you create sustainable clinical medicine. Thanks for listening.